to invite Dr. Hom Hidayah to start the sessions for this CPC. Thank you.
Okay, thank you, Prof. Yazid. Assalamualaikum. And a very good morning to everyone. My name is Dr. Homi. I'm one of the registrars from Food and Ankle team. Thank you for listening to our CPC today. So I will start off our CPC today with this is the tentative for our CPC for today. The title was Bone Without Flesh, Strides for Hope. So I will start off with case presentation first, and then it will be followed by discussion and management, post-operative care and physiotherapy, Q&A session and conclusion, and the last session will be Kahoot session. Okay, so this is the title for our CPC today, Bone Without Flesh, Strides for Hope. All right. Okay, so our patient was Mr. N. He was a 44-year-old gentleman with underlying diabetes and hypertension. Initially, he complained of bilateral lower limb wound, pain and swelling after came back from Umrah in February 2023. It was associated with past discharge from the wound and also fever and lethargy. Otherwise, he denied having any history of trauma or any preceding event that might have directly caused the symptoms. At first, he went to multiple private centers to look for medical treatment. He initially treated with antibiotics and multiple wound debridement. Subsequently, he was advised by the treating surgeon to go for amputation of his left lower limb. However, the patient was not keen with that treatment option. So he opted to come to our center for second opinion. All right, so at presentation in our emergency department, he was generally unwell, septic looking, pale and mild tachypneic. In terms of his vital signs, the BP blood pressure was on the higher side. He was tachycardic. He is still febrile with 38 degrees Celsius, and his oxygen saturation with slightly low with 95% under room air. So at this point, he was basically in sepsis. Okay, next is his lower limb condition. This was his right lower limb. As you can see from the photo, there were a multiple skin lesion with sloughy base at the lateral side of the ankle with surrounding necrotic patches, and the surrounding skin was also erythematous, showing ongoing infection. And anteriorly, there were multiple dry skin lesion seen, and also the skin erythema extending anteriorly as well. And for his left lower limb, this is where the multiple wound debridement was done. As you can see, the wound base was still sloughy. This is the bone exposed over here, the tibia bone, and there are multiple tendons exposed as well. And the skin edges was also not healthy. And proximally, you can see there's a huge necrotic patch with surrounding erythematous, showing that the infection is still ongoing. Okay, so next, to further guide our diagnosis and management, we proceed with investigations. There are a number of investigations we have performed for this patient. Okay, so the first one were blood investigations. So these are the blood results when he was initially presented to us in emergency department. So in terms of his full blood counts, he was obviously anemic with hemoglobin 9.7. His total white, however, 8.5, which is actually within the normal range. This is most likely because he was already partially treated 2 weeks priorly with antibiotics and the multiple wound debridement. And apart from that, his renal profile was quite okay, apart from low potassium, which is 3.1. However, the CRP, which is C-reactive protein, it is a blood marker for infection, is quite high with 13.93. And in terms of albumin, is very low with 17. Okay, it may be one of the reasons of why the wound was not healing well. Okay, so in terms of radiological investigation, actually, we also did plain radiograph for this patient of the bilateral leg, tibia fibula plain radiograph. But this radiograph will be explained further by our radiologist, Dr. Juliana. So apart from plain radiograph, we also did CT angiogram of bilateral lower limbs. Okay, why? Because we need to assess the perfusion of the patient's bilateral lower limb to further guide our management later. Okay, so the finding was there was a mild to moderate bilateral below knee atherosclerotic disease, 25 to 75%, with almost all vessels are opacified. Sorry. So this means that despite having atherosclerotic changes, the perfusion is still present of his bilateral lower limb. Okay. So next, after we obtained history, examination, and investigations, we managed to list down our differential diagnosis. Okay, so this actually was listed according to from superficial to deep layer, condition of lower limbs, including possible vascular disease as well. And based on what we have gathered from our history, examination, and investigations, our provisional diagnosis was necrotizing fasciitis. Okay, so why? First, because of the initial rapid progression of the disease. Okay, because it was a very short history. And second, the severity of soft tissue manifestation, because as you can see from the photos that I've shown before, it affects from skin until fascia and muscles, whereby the previous surgeon had to remove everything to control the infection. And also there is systemic toxicity as well, or sepsis, shown by the patient's vital signs and the general inspection. Okay. Right, so to further enlighten us regarding plain radiographs and other imaging findings of necrotizing fasciitis, I would like to invite our musculoskeletal radiologist, Dr. Juliana.
All right, thank you, Homi. So first of all, Assalamualaikum and very good morning to everyone. Thank you for the organizing committee for inviting me. So the outline of my presentation will be as listed here. So let's look at the imaging radiograph that has been done for this patient. Next, please. Okay, so we have here is the posterior ankle. I cropped the radiograph already. This is on the right and as well as on the left. So you can see approach first for the undergraduate student, approach on the radiograph. Normally, previous. So, okay, so what we are seeing here, we should see the bone first for any abnormality. Apart from the calcaneal spur that we can see in both of the calcaneum, there is no bone lesion or suspicious lesion seen in this radiograph. But just to point out that we are seeing the soft tissue, the heterogeneity of the soft tissue, we can see that it is swollen. You can see the subcutaneous is swollen and with a lucency appreciated, especially obliterating the cagous fat pad bilaterally. On the left side, as we remember, we have a radiograph, we have a photo showing there is an open wound there, and definitely there is also tracking lucency that is seen at the posterior aspect here, towards the along the facial plane posteriorly. Okay, next. So just to for you to differentiate the normal one is the one with the label. Look at the Kager's fat pad. So we can see the heterogeneity on our patient. The Kager fat pad is no longer homogeneous. It's definitely heterogeneous with lucency. You can appreciate that lucency is indicating of edema as well as the gas tracking along the facial plane. Incidental finding of a vessel that is also calcified, also showing us that this patient might probably a peripheral arterial disease or atherosclerotic plaque in its vessels posteriorly here. Next. Next, please. Okay, so this is to show you another zoom out image of the radiograph of tibia fibula. You have an implant situated there with some periosteal reaction and callus formation due to the previous surgery. But what I wanted to highlight here is the soft tissue. You can see heterogeneity, and zooming out of the radiograph, you can see that the lucency is tracking along and going proximally along the deep facial plane on the medial aspect on the right side, as well as the lateral side and at the lesser degree. You can appreciate on both of the legs with the wound breakdown you appreciated. Yes, you can go next. I'm just going to show you again. This is a normal radiograph that it should be looking more homogeneous. You can see the soft tissue or the muscle is homogeneous of intensity. The only lucency we are seeing is the subcutaneous fat, because fat is also lucent on radiograph, but the heterogeneity and the lucency is even more on our patient, indicating that might probably a presence of air within. All right. Okay, zoom in picture. I just want for you to differentiate and realize that the heterogeneity and the swollen of the our soft tissue of our patient as compared to the normal radiograph. This is after 6 months. Again, remember the radiograph just now. Now it's already resolute. The soft tissue swelling, there is a bit of residual air and residual soft tissue edema. You can see there. But now there is presence of periosteal reaction. This periosteal reaction is benign. It's more towards periosteitis or reactive changes due to the treatment or the management by the primary team. However, is not indicating of aggressiveness. Aggressiveness such as osteomyelitis and aggressive Codman's triangle, we've learned about that. It's showing more aggressive in nature. However, in this patient, you have benign solid periosteal reaction, showing this is just a reactive changes of the management. Definitely what I'm just showing you here is just wanted to show you that there is more homogeneous opacity of the soft tissue after the 6 months of treatment. So let's move on to necrotizing fasciitis. So this is the provisional diagnosis for this patient. What is it? It's an aggressive soft tissue infection, definitely in both of the soft tissue in the subcutaneous region as well as the deep fascia. Etiology-wise, let's go to next. Etiology-wise, it is mostly commonly in immunocompromised patient because there is infection going on. Recent trauma or wound breakdown is also a source of the infection, and definitely if this patient has a vascular insufficiency like our patient just now, it also predisposes this patient to have a necrotizing fasciitis happening. And definitely our patient is also diabetes, again another increase and a predisposing factor of patient having a necrotizing fasciitis. Next. Imaging wise, what we are trying to look is gas. We are looking for gas collection that is lucency inside the radiograph. We are seeing it along the facial plane. If we can see that, it's almost pathognomonic or almost certain that it's a necrotizing fasciitis. However, it's only been seen less than 50% of the cases. Definitely, if clinically is indicated of a necrotizing fasciitis, negative imaging shouldn't prove otherwise. Subcutaneous edema may be present in most of the cases. However, subcutaneous edema is not specific, but can happen in necrotizing fasciitis as well. So let's look at the best diagnostic clue. Best analysis clue, this is actually MR imaging. We are trying to see for facial thickening. We are trying to see the extension inside the multi-compartment. We are trying to look for gas. And if we do a contrast study, we can appreciate the necrotic area of the muscle tissue or the deep fascia. But however, in our patient, we only have radiograph and clinical findings is already certain that is an NF. No need for an MR, especially if this patient is quite unstable and very sepsis. So this is not our patient, but this is one I wanted to show you a more severe cases. This patient has an amputation. As you can see, there is absence of the toe. All right, the lucency or the gas shadow is more exuberant in our patient. Subcutaneous edema is also swollen, and this is highly related to a necrotizing fasciitis findings. Another image that I found, this is not your patient, but this is the open arrow is just to show you that the lucency or gas is actually tracking along and proximally along the facial plane of the deep fascia. So this is also necrotizing fasciitis in a severe case. We can also do a CT. Why is it better? Sometimes it has our 3D dimension. We can see in cross-sectional imaging. It aids the surgical if for surgical planning, definitely, and it's more sensitive to look for lucency. If the radiograph is not showing you any of the findings that we've mentioned before. So again, there is lucency, the gas collection is more exuberant, and we can see it on bone setting. Okay, in these instances, this patient has intra-abdominal extension and it's along the psoas muscle on the right side there. So this is another case of a very severe necrotizing fasciitis. Ultrasound, we can do ultrasound definitely if the radiograph is negative. And ultrasound is mainly due to pediatric patients. Sometimes we can do an ultrasound to look for the presence of air. As you can see from the image picture here, the arrow is pointing towards an air. Air is hyperechoic on ultrasound. It casts a bit of shadow, so we know that there is air within. Gas collection is, and also the location of the gas is mostly quite specific for necrotizing fasciitis. The open arrow here is to show you that the muscle is hypoechoic or a bit more necrotic, and this can depict on the ultrasound. Another one more thing is the deep fascia non-enhancement and necrosis. We can see fluid as well. And this is also to aid if there is need of a biopsy or any aspiration to guide the aspiration, and we use ultrasound for that. Okay, next. Next slide, please. Okay, a bit on the radiological differential diagnosis. Definitely the one listed in the prior slide is the necrotizing fasciitis, non-necrotizing DVT, compartment syndrome, cellulitis, lymphedema. All of these has similar findings of a soft tissue edema. Patient can have a bit of redness, patient can have soft tissue edema, very swollen leg. However, if you do a radiograph, there shouldn't be any lucency such as gas within the radiograph. So all of these are looking at soft tissue edema, but no gas. So these are the differential diagnoses in clinical patient coming in with subcutaneous edema. So last slide, the key points is to have the best imaging tool for necrotizing fasciitis is radiograph. But clinical diagnosis of necrotizing fasciitis is so exuberant that sometimes imaging may not be required. Radiograph can be entirely normal. Gas is only present in less than 50% of the case. Sometimes CT is needed. In stable patient, we can also do MR for more specific patient, but then again, should not be undertaken if the patient is unstable or sepsis. And the utility of imaging is to aid the necrotizing fasciitis, but clinical judgment by the clinician and from the organizing team is the definite diagnosis. So with that, thank you so much for your attention.
Thank you very much, Dr. Juliana, for the radiological part of the necrotizing fasciitis. Now I would like to proceed with management of necrotizing fasciitis. For the management part, the combination or integration for the management part, the combination of integration of medical and the surgical approach is really valuable to treat the necrotizing fasciitis. And for early management, patients always come to us with multiple complications such as acute kidney injury, then anemia, and then uncontrolled diabetes, even patient got DKA. So we have to replace the fluid and maintenance and the correct electrolyte imbalance. And we have to optimize the hemoglobin as well and give the proper nutrition, specifically the protein such as the albumin to enhance the wound healing afterwards. And then after we optimize the medical condition, patient is fit to undergoing to remove the unhealthy and non-viable tissue by do the wound debridement. And then for the antibiotics, we have to give the broad spectrum antibiotics to target the common pathogen that involve in the severe soft tissue injury. However, due to aggressiveness of the pathogen, the potential antibiotics is based on the CPG guideline in 2019. The best is the tazocin 4.5 gram TDS, and optional plus minus, we can give the clindamycin 600 milligram TDS as well. And then after the operation, we have to think how to enhance the wound healing by do the proper dressing regime, and then the last one is the wound closure. This is the picture of after the first wound debridement. We can see there is a big wound over the left leg and right leg. This is considered a good debridement for this patient. By evidence, there is a good muscle color, and then educate the margin. Even there is a exposed of part of the left tibia. And for the right leg, there also a good wound debridement did for this patient. Even with multiple slough seen, we can address this by using the daily desloughing for the patient. Then there is an option of wound closure. For the option is there is a negative pressure wound therapy or NPWT, and then split skin graft. And there is other option which is a flap that under plastic and reconstructive surgery, but we rarely do this in view of the risk of infection is high, and of course in view of the wound is very big. If we do the flap, there is another morbidity for the patient, and there is the risk also of amputation. But this kind of treatment we only reserve for the patient that not respond to our early management, like antibiotic, wound debridement, and then patient got very severe sepsis that involve multiple organ failure. That one, the life come over the limb, so we have to amputate the patient. So after the wound debridement, we start first with multiple cycle of negative wound pressure. These modalities is by to remove the excess exudate that contribute to the clean wound environment. And to do this, the edema also reduce, and it will promote the blood flow to the wound, and thus exaggerate the wound healing. Then by doing this also, we able to achieve the stimulate the granulation over the wound area. Then if a patient fit to discharge, there is a other option that we can give to the patient, which is the portable negative pressure wound therapy. So here is the picture how the portable vacuum pump looks like, but the is optional also for the patient as it's very a bit costly. So sorry, the slide is a bit lagging. Okay, this is the wound picture after 12 weeks or 3 months post wound debridement and multiple cycle of the vacuum therapy. We can see there is a good granulation tissue that coming out surrounding the wound. Then at this stage, we have to take a tissue sample to make sure there is no active infection that we can ready the patient for the procedure as what we known as a split skin graft or SSG. So what is SSG? SSG is we take the amount of skin tissue from the donor side and then we mesh it using the special instrument and then put it on the recipient side and we secure it with a suture. As you can see here, the donor side, we take part of all the epidermis and part of the dermis and detach from its own blood supply and place it to the wound site. So this is how the wound looks like after the split skin graft procedure. You can see there is more than 80% intake of the initial wound over the left and right leg. Over the time, this wound, you can see there is more granulation tissue come out from first week, 4 weeks up to 3 months. And the last result is this one. The wound is totally healed. Then of course, along the time, we have to stabilize the ankle by using the S-fix or the back slap to make sure patient can plantigrade after the long hours of management. So after the wound heal, we subject the patient for physiotherapy. The best to talk about this, I would like to invite our physiotherapy, which Nurse Suryati Ahmad Kaus.
Thank you, Dr. Nur. Okay. Hi everybody, Assalamualaikum, and I'm Nur Suryati. Okay. This is overview what is our management for patient with necrotizing fasciitis. Usually, patient with necrotizing fasciitis have increased risk of reduced endurance and strength because of infection. So then our treatment mostly on prophylactic chest physiotherapy, such as breathing exercise, thoracic mobility exercise, and to prevent reduced muscle power and range of motion. So we do the mobility exercise, and not to this to prevent the pressure sore by positioning and mobilization. Okay. For the next slide, I will talk about the patient case. This case is referred to us in the ortho ward, and then the patient has been warded for 84 days. During this prolonged stay, of course, the patient will be sent with complaint of anxiety because of the large wound. And at first, usually the patient will always thought that I just done the operation yesterday, so and today you want me to do the exercise. That is the common the patient will give the excuse to excuse the exercise. So then we have to pursue the patient and then to start with the non-painful joint, such as start with exercise upper limb and then proceed to the lower limb. not to forget the breathing exercise and relaxation technique. And then once the patient is gained the confidence and believe that the pain and the wound are not their primary obstacle, to actively move, so we start to progress the rehabilitation by bed mobility. The bed mobility, actually we have to start as early as day 2 of referral because to prevent lung complication. All right. So for the next slide. And then of course there is time in between the prolonged of stay. The patient have the fluctuate condition, which is sometimes patient cannot do the exercise, and then we have to slow down the treatment. But then when the patient has achieved the positive outcome, so we use the target food therapeutic exercise, the mobility, bed mobility, and then progress to the transfer technique, and then enhance the patient functioning independently. And until the patient get expressed because of this, because want to early discharge. So the main goal is to return patient to independent stage. Okay. For the next. Okay, so the progress of the intervention, which is strengthening exercise, lower limb, ROM, which as the wound affect the joint, so we limited the range of motion. So to prevent this, we have to do the exercise based on patient performance on that day. If the pain is controlled and then the patient can tolerate the pain, so we progress to do the stretching, to do the strengthening exercise such as inner range squat, straight leg raising, and sit to stand. Sit to stand with the walking frame. And at the end to this, prior to discharge, patient managed to gain the improvement in functional mobility and the transition from independence to the functional, and patient able to ambulate with the walking frame at least for 2 meters with the wound. So in this case, actually we want to highlight that is early mobilization. And actually, early mobilization is defined the physical activity that is carried out to appropriate intervention, benefit of the body, and improve circulation, peripheral and central perfusion. And then the early mobilization can be not only mobilized is out of the bed, but it's also consists of the passive, active range of motion, active side-to-side turning, bed mobility, and then some cycling in the bed. This is usually we do in the ICU. Exercise in the bed, sitting at the end of the bed to improve the balance, to improve the proprioception of the leg. And then teach the patient the proper way how to transfer, self-transferring from bed to the wheelchair. And then from before start to ambulation, usually we ask the patient to do the marching on the spot and proceed to ambulation. Sometimes, not this case, sometimes if the patient has difficulty, so the hoist therapy and the TEET table is help. So the active resisted exercise and some of the patients need the muscle stimulation to improve their functional mobility. So that the early stage of mobilization. So the mobilization is not only moving out the bed. Okay, so that the conclusion of the patient. Thank you.
Okay, thank you, Sureti. So I will continue for the discussion part. In summary, our patient is a young diabetic gentleman, age of 44 years old, with these 4 main problem lists. He presented with infection, so she already debrided and treated with antibiotic, which left him with a large wound over the bilateral lower limb, which we managed with appropriate wound dressing and wound care, and complicated with the tibia bone exposed over the left lower limb. So we managed with vacuum dressing
until the granulation tissue already covering all the bone and we covered with skin grafting. And he also has weakness of both lower limb, where the physiotherapists come into the picture for rehabilitation and to restore the function of the patient. Alhamdulillah, we were able to manage all his main problems successfully. The patient was very satisfied with the outcome of the treatment. Most importantly, he was very grateful that he still has both of his lower limbs. His power he's regaining back his power of the lower limbs. He's able to ambulate without aids, and he's already preparing to start to return to work soon. So good wound care it started from a good wound assessment and also appropriate wound treatment. So this time is acronym of a clinical tool to guide us to properly assess the wound and come up with appropriate management according to the wound condition. Because the wound actually come in stages, right? So T stands for tissue. So if the tissue is necrotic and slough, so we need to debridement. So our aim is to get a viable, healthy wound bed. I stands for infection. We treat with antibiotic. M stands for moisture. So moisture of the wound is one of the important factor for wound healing. So it's either dry wound or exudative wound. Exudative could be mild, moderate or severe exudative. So this will guide our choice of dressing to maintain the moisture balance of the wound so that the wound can heal better and close later. So if a dry wound, the selection of dressing could be like hydrogel or hydrocolloid. If exudative wound like mild, moderate or sedative wound is either hydrocolloid or non-negative pressure wound therapy or vacuum dressing. So E is the age of wound. So our aim is the advancing age of wound. So in this assessment, so usually our aim of treatment is to get re-epithelialization, and in the end we get closure of the wound. So if the patient, the tissue is non-viable and unhealthy, so we proceed with wound debridement. So the aim of wound debridement is to remove all the devitalized and infective tissue. So the end result, we get a healthy, viable muscle by evaluating color, consistency, contractility, and capacity to bleed. These are the example of type of dressing that we can choose. There's a various type of dressing in the market, but you can actually choose what dressing you want to use depending on the assessment just now. So there's also type of dressing which have drug loaded with silver, povidone and antibiotic for antibacterial agents. So for vacuum dressing or negative pressure wound therapy, so it's very good dressing modality for especially if you want to for highly exudative wound and you want to increase the granulation and you want to advance the age of the wound for re-epithelialization. So the benefit of negative pressure therapy is actually it's reduce wound edema, improve perfusion, stimulate granulation tissue and angiogenesis, and it can reduce the need for plastic procedure or more complicated procedure for closure of the wound. So nothing is impossible. If you see at the first picture, you think that it's impossible to salvage the limb, right? Because it's very extensive wound and the bone is exposed. But with proper wound assessment, management of the patient as a whole, and also wound care, patience and determination, both from the treating surgeon and treating physician, and also the patient also have to be cooperative in the process of healing. So end up, we managed to close the wound properly. We can salvage the limb, patient can gain back his function and return to work and reduce all the comorbidity. So for the key learning points from this case our presentation is, the first important thing is eradication of infection, diabetic control, proper wound debridement and wound care are the important factors to determine good wound outcome. And closing a diabetic wound with exposed bone can be accomplished through a split skin grafting procedure once the bone is adequately covered with granulation tissue. So this was facilitated by vacuum dressing. And the most important thing is Sectional wound care as a holistic in a young diabetic patient can prevent limb amputation, leading to improved functional outcome. So I will invite Professor Yazid to give a presentation.
Thank you, Miss Liana, and thank you to all the speakers for very excellent talk just now. So I will open a Q&A sessions for any burning question that need to be asked, either to the speaker, any of the speaker from the orthopedic side, from the physiotherapy side, and also from the radiological side. So is there any question? If there is
Assalamualaikum.
no question,
Assalamualaikum, Prof.
Waalaikumsalam.
I'm Afira, actually physician. I just want to ask actually regarding imaging. So how you choose actually patient for CTA, or when they presented with NF, when you decided for CT imaging, so when actually you go rather than just a normal radiograph?
Okay, I will give the question first towards the radiologist to answer, and then after that I will elaborate a little bit on that. Miss Dr. Juliana, will you jawab?
Sorry, Dr. Juliana has to leave because
Okay.
she has
Okay, if
Viva.
Dr. Juliana have to leave, okay, I just answer the question. Okay, in regards to the which part of the imaging that we tend to offer towards the patients, it depend on the conditions of the wound after the initial assessment. But the basic needs is usually is the X-rays. Okay, and then the X-ray basically we want to see, as just now been explained by the radiologist, what's the gas shadow and everything, and then regarding any kind of reactions towards the soft tissue. And then with the suspects, there is a collections or anything. We want to know how is the extent of the collections. We proceed to the ultrasound. And if the wounds looks dry and then the pulses is not that good, not that great during the assessment, only then we can proceed with a CTA. This is usually we done with collaborative with our vascular team. Usually we ask the vascular team to see and then give their opinion regarding the wound conditions, whether there is a need for a CTA or not. And then after that, if the vascular teams thinks that CTA is amenable for these patients, so we will proceed with CTA. Most of the time, if the patients have a good vascular supply, the result will be good. If it's not a good blood supply, most of the time, patient will end up with amputations. So the key now is the vascular assessment also. So I hope I answered the question. Is there any other question? If there is no question, we already prepared a Kahoot question for the students to answer. I will give Dr. Norliyana and Dr. Homi to give a Kahoot question. Maybe we prepared 5, but I think due to the time, we just prepared 3. We give 3 questions.
Prof,
Right? Yes.
before that, I will invite the Encik Buhari to share the slide, the link for CPD before we proceed to food.
Can you Buhari, have the link been distributed? Can be.
Okey, saya dah share link dekat ruangan chat. Sekarang saya akan share untuk quizzes, untuk soalan quiz untuk medical student. Okey, terima kasih.
Thank you. Okay, we can start the Kahoot.
Okay, boleh saya start sekarang sebab saya tengok
Boleh.
ramai yang main ni, ramai yang nak masuk ni.
Boleh dia start.
Sekejap, sebab dia orang tengah masuk. Sekejap Prof
Okay. This Kahoot, who's get the highest mark will get a prize. Okay, so answer it properly. The prize can be we already have the winner on style, and then another one there is no name.
Okay, dah.
Alright. Okay, guys. Later you can take the prize from me in our department, orthopedic department later on. Okay. I think we already come towards the ends of these sessions of CPC. I hope everyone have learned and get good knowledge about how to manage the wound. And I think there is a few lessons or conclusion that we can draw out from these presentations and a take-home message. First of all is
Okay Prof, terima kasih. Saya share link untuk CPD
ni, I tak habis cakap ni. Sekejap. The link CPD boleh share sambil I
Sorry, ingatkan habis.
Belum habis lagi. Alright. Okay. The lessons and another thing is about the take-home message. I hope you guys, especially the medical student, and understand how to manage the wound. Okay. The most important thing is about the holistic patient care is essential, and always look beyond the immediate surgical needs, and also considering the factors like infection control, diabetes management, and also psychological well-being. Another important thing is always innovations in your treatments, not only play by the books, but it's depend on the conditions of the patients, situations of the patients also, and also if you do have and can embrace any kind of advanced technique that you have, although it's not being done yet, you can try it as the benefits towards the patients. And always important, the importance of wound care is the most important thing is on a proper wound development and a dedicated wound care. And the most important thing is restore back the functions. And then lastly, the power of optimization and perseverance. So you have to remember that our effort is not only the effort from the surgeon, from all the collaborative other departments, but also come towards the patients. So at the end of the day, our treatment basically the needs of the determinations from the patients also quite an effective factor towards our success towards the treatment. So how you want to gain the determinations from the patients is that first of all start from the surgeon itself. Okay, with that I conclude our CPC. Always trust our treatment, and nothing is impossible in medical treatment. Okay. All right, with that, I thank you, everybody, and hope everyone have gained knowledge towards these sessions. Thank you, and I pass back to Encik Buhari for the CPD link.